Hello, welcome to EASL Studio, your weekly hepatology broadcast news. I am Sven Francque, I'm a hepatologist at the University Hospital of Antwerp, and I have the pleasure to be your host today. We tackle the little bit provocative question whether we can solve MASLD by treating obesity. That's what we will discuss today. Now, 2023 was an important year because we changed the nomenclature. We left behind us non-alcoholic fatty liver disease. We're now talking about metabolic dysfunction-associated steatotic liver disease. And one of the aims of that change in nomenclature was to really point out that metabolic factors like obesity are important in driving this disease. So the question is really relevant. Can just by treating obesity, can we solve the problem of MASLD? It's more particularly relevant now because 2024 also announces to be a very important year for the MASLD field. We are expecting, the community is expecting, that in the upcoming months we will have the first anti-NASH drug approved. So that will change the landscape, or probably not, because we have already some tools to treat obesity. And I have some very eminent colleagues here with me to discuss this topic, and I just would invite them to briefly introduce themselves. Cyrielle?
Good evening, everyone. I'm Professor Cyrielle Caussy. I'm a diabetologist and nutritionist at Lyon University Hospital.
Thank you, Dimitris.
Hello, I'm Dimitris Papamargaritis. I'm one of the associate professors in diabetes and endocrinology at University of Leicester.
Thank you. Willem, Pieter?
Hi, everyone. Good evening. I'm Willem Pieter Brouwer, and I'm a hepatologist in the Erasmus University Medical Center in Rotterdam in the Netherlands.
So thank you very much. So you see a mixed panel to discuss this topic. And one of the first things I think we need to discuss is, if this disease is indeed in part driven by obesity, how can the treatment of obesity positively affect this disease? What are the mechanisms? How far do we get with this treatment? Cyrielle, please. What's your take on that?
I think it's an excellent question. It's also complicated because it's always the question whether we have this accumulation of metabolic factor. We have obesity, probably in some patient type 2 diabetes, and then we have MASLD, as we call it now. So trying to identify whether you improve one of the factors will impact the other factor is something that is highly relevant. We do have some data that has been produced a long time ago demonstrated that if you achieve a weight loss greater than 10% of the initial weight loss, you will have an improvement in MASLD, in hepatic steatosis, in NASH, potentially in fibrosis as well. But the question is it always, we've seen also that it's difficult to achieve this 10% of weight loss. And no, we have multiple tools to address this issue about treating obesity. We have new therapy that have been approved also. It's been a really moving field for the obesity treatment. And what we do see is that probably this will impact the treatment of NASH as well. But what is really interesting is that the therapy such as semaglutide that is now approved for the treatment of obesity is also under development for the treatment of MASH. We don't have all the answer because the study is currently ongoing in phase 3, but very promising results from the study in phase 2 in a randomized control trial where we did see improvement in NASH or MASH, but did not see any improvement in fibrosis, which makes us wonder whether it would be a tailored intervention depending on the type of improvement you're looking for. Do you want to improve NASH? Are you targeting more severe patients with advanced fibrosis where we see that it may be less efficient? So we still have a lot to understand. For sure, there's a benefit in losing weight in any means, but we need to understand better the liver impact of these new therapies, and this is currently ongoing.
And Dimitris, there's also, we know that if you have 3% weight loss, 5% weight loss, 7% weight loss, it can make a difference. Why is the amount of weight loss potentially important? What's the mechanism behind it?
I think that we look about thresholds of weight loss that they improve specific complications related with obesity, and we should think about MASLD and MAS as one of these complications. So the most recent data from the bariatric surgery, which a big trial published recently in Lancet called BRAVES, demonstrate actually that if you achieve 30% weight loss with a gastric bypass or 25% with a sleeve gastrectomy, this not only can improve the inflammation from the mass, but also can improve at least one stage of fibrosis for this population. So, and the benefit was additional up to the weight loss of 20%. After 20% weight loss, the benefit was less. So this gives you approximately what could be a weight loss target that you need to achieve with without medications. For example, in order to see these improvements that you want to see, you may see improvement in inflammation at 10% weight loss, and you may see improvement in fibrosis in more than 20% weight loss. And as Cyrielle says, we have not only semaglutide, which has been approved, but also tirzepatide that has been approved currently for weight loss, which is very important because we need to think about treating the disease of obesity. The problem with the lifestyle interventions is the weight regain. So at the time that your body is in a weight loss state, what will happen is that your appetite will go up and your energy expenditure will go down. Your body wants to push you back to the weight that you were before. And that's why it's so difficult to lose and maintain the weight loss. And that's where the medications that suppress appetite that we have currently are coming. And that's the main help of these medications is to help not only lose weight, but maintain the weight loss. And whether these agents will have a dependent effect on liver outside the weight loss that we can achieve with this is something that is under investigations. The most promising of these medications probably will be in the next generations, the ones that will have also glucagon into this. Some initial data suggests that these are very effective in reducing the fat, the steatosis into the liver. However, whether they improve inflammation or they improve the histology, this is something that has not been investigated and needs further investigation.
Mm-hmm. And do you think it's important, this weight lowering treatment at any stage of in the spectrum of MASLD MASH? Pieter, what do you think?
I think so, actually. I think that it's probably better to eventually start earlier. So now in the trials we have the trials formed in F2, F3, or even F4. But I think that if we treat it earlier, that we can probably prevent the complications of going to the liver disease and having liver fibrosis. So yes, so my take would be to start a little bit earlier. But right now we have to first prove that it really works, and that we also see fibrosis regression. And this is a really difficult question because indeed, like with weight loss and with gastric bypass, so we've seen a lot of improvements in fibrosis, and with the first trial in the semaglutide, not yet, but maybe in the phase 3 trial we'll see this. So this is not something we can say just yet. But if we look at those trials in with gastric bypass and with weight loss, then I think that it's achievable, and even so after longer periods of time, because I do think that we sometimes need to give it a little bit more time to achieve fibrosis regression, actually. Because I do think that if you take away the etiological factor, like fatty depositions and inflammation, then after a while, and I don't know how long, but I would think that it would improve, and that's what you also see in the gastric bypass studies, actually. So yeah, but if you look even further, so we have the last trial in semaglutide for cirrhosis, then the conclusions are that we don't see the regression. So that's possibly too little too late, but also if you look at trials in gastric bypass and cirrhosis, then after longer periods of time, you do see a regression of fibrosis. So I'm quite hopeful for that, but I don't think that we should wait until the later stages.
I think indeed I would like to challenge that a little, because in the bariatric surgery trials with long-term follow-up, you do see patients that do not regress fibrosis, especially F3, F4 patients. Some of them seem to improve. The numbers are better after 5 years than on the baseline biopsies, but still in some of the patients, the stage of cirrhosis is not resolving, and it's also what we saw with the semaglutide.
Yeah.
Curious to hear also Cyrielle and Dimitris' take on the fact that with semaglutide, for example, in the trial, despite the 1.5 years of treatment and substantial weight loss, substantial effect on the steatohepatitis, which is what we conceptually think is the driving force of fibrosis. Nevertheless, there was no regression of fibrosis. A little bit puzzling and a little bit challenging that treating obesity really solves the problem of MASLD or not.
I think you totally agree, and we've already tackled that, but just to go further, probably there will be therapies that would be most suited for early stage. We don't even mention hepatic steatosis, just the very beginning of the disease, very, very early stage. This is where we have the most benefit of weight loss therapy, including bariatric surgery. So this is also a way to completely cure the disease. You don't even have a significant amount of hepatic steatosis in the liver, so you completely reverse the presence of MASLD. And then when we move around the different stages, we clearly see that it will be more challenging to achieve a regression of fibrosis, especially in the specific population F3 compensated F4, as we talked about the trial that have look at the efficacy of semaglutide 2.4 compared to placebo, and we did not see a significant reduction of fibrosis stage. However, what we did see is a decrease in some parameters that are associated with fibrosis, which seems to indicate that there could be a benefit, but it wouldn't take longer to demonstrate. The other key take-home message is that, and we've shown that in the phase 2 trial, again with semaglutide, when we look at those who progress, and we clearly see that it seems that there's a lower proportion of patients that will progress towards increased stage of fibrosis. And this is also very clinically relevant. It's really challenging to design the perfect study that could show that there's a benefit in terms of progression, because you would need a lot of patients and a long duration of time potentially. But at the end of the day, if we are able to maintain the patient of the zone of advanced fibrosis, if they stay in this zone where they may have some lesion of NASH, but they will never progress to the more severe stages, this would be also very important. And potentially as well, and this has been something, a concept that has emerged a few years ago as well, we know that we probably will need multiple combination of therapies, that one could target more inflammation and hepatic steatosis, induce weight loss in order to make sure that there will be no relapse, because we mentioned the relapse of obesity. We are quite aware as well that even if we achieve a resolution of NASH at some point, what we don't want is that the patient relapse and they go back to a state where he will gain weight again, have again liver inflammation. So with combining multiple therapies, then you can have a therapies that would regress the lesion of inflammation, fibrosis, but also prevent the main driver, which is probably increase of weight loss along the time. So I think this is really important.
Yeah, and you also touched upon an important point that it's not just regression of fibrosis, but also the absence of progression. And progression to cirrhosis has been proved as an endpoint in clinical outcome trials. So that could be right for sure. Dimitris, you also touched about glucagon, and we have, of course, the dual and triple agonist. Do you really think that might make a difference in terms of mechanism of action beyond just weight loss and have an impact on fibrosis or not?
I don't know about the impact on fibrosis because there is no evidence, or I'm not aware of evidence regarding this. But regarding the steatosis at the liver, there is clear evidence that, and published evidence also, that the new agonists, one of them compared directly to semaglutide for diabetes dose, the 1 milligram, and the one that the comparison was efinopegdutide is the medication which is undergoing currently clinical trials for MASLD and the MASLD, and demonstrate that the combination of GLP-1 and glucagon led to 70% reduction in liver fat compared to 40% reduction with semaglutide for similar amount of weight loss. So there is a weight-dependent effect, a direct effect to the liver, which is actually probably due to lipid oxidation that is happening with glucagon and reduce the fat into the liver. Now, whether this will be translated to histological improvement and improvement in fibrosis, this is what the trials, the phase 2 trials that are ongoing, probably will give us some initial evidence regarding the GLP-1 and glucagon agonist. And I think that another one way of thinking, except of if we're looking about specific fibrosis, it may be that we combine the weight loss that we achieve with GLP-1s and all of this with medications that may have established effect on fibrosis, like the FGF21 and things that they have more benefit on fibrosis. So my view on what should be the time point that we intervene actually, we know, I just have in my mind the concept of diabetes. We know that we can create diabetes remission the earlier that we intervene, okay? But whether this will be a cost-effective way and whether we can identify who is having a higher risk of progressing, so you focus on this population through a marker, biochemical marker or whatever, I think this will be important for the future, because obviously bariatric surgery is not scalable in population level to achieve this amount of weight loss. But if you have to use medication and you use the medications in a cost-effective way, so people will have equivalent access, you need to identify who will be the people that will benefit more. It's very likely that you cannot use to all the people with MASLD. You need to identify people with MAS that they have the higher risk of progression. That's my understanding as diabetologist, at least, of how it could be the concept.
Yeah, but it's a challenging point because indeed, yeah, do we need to treat just steatosis, or do we, for cost effectiveness reasons, just focus on more severe types of disease, and how will we identify them, and who is going to do what? Willem, Pieter, what's your take on that?
It's a really difficult question, actually.
No.
Indeed. Yeah, but I agree with Dimitris that it's very important that we have like a cost-effective treatment, and we cannot probably treat all patients, but I do think that we need a holistic approach. And this is something we can achieve with this type of medication, indeed, and it's well, it's probably I think that we could go for a cost-effective strategy if you tackle more comorbidities, right? So with cardiovascular disease, diabetes, and also MASLD. So, but the question is if you need to treat someone with only MASLD for with probably one comorbidity with this type of agents, that's I don't know. I do think that we need more information about the natural history and how it further progresses. data still a little bit lacking in that area, and to further identify patients who will have a aggressive disease course in comparison to those who will actually not have such a course. And I do also think that that we need to focus on age in this matter, because the older the patients get, what we've seen in population-based studies actually is that that these patients do not really die of liver disease, but really of cardiovascular diseases. That's something to have in mind, I think. And we don't have the answers for that right now, but something to consider.
I think if I can just comment on this, I totally agree. And I think there's a lot of things that we can actually learn from the field of diabetology, or at least there are many similarities that can be applied here, and even in the field of obesity, regarding timing of drug implementation or intervention, because for example, prior to bariatric surgery, you need to at least engage in a lifestyle modification program. And even though we know it's challenging and that we will not achieve 100% of improvement through lifestyle intervention, there are some patients that respond pretty well. And for those patients, probably it's okay. They will engage, change their lifestyle, and there won't be needed to engage in further medication or intervention. On the other hand, and I totally agree, the holistic approach, trying to understand the way we will tailor the intervention and which treatment would fit better to which patient in terms of like precision medicine, which is really a field that is moving forward. We can also totally take into account the fact of the presence of cardiovascular disease. This is already implemented in the guidelines for diabetology, when we would prefer some treatment, such as inhibitor of SGLT2 inhibitors or GLP-1 receptor agonists, because they have demonstrated a benefit. So providing that we also confirm this protective effect with some drugs regarding cardiovascular events, we would need to, prioritize the patient with already the highest cardiovascular risk, or the patient that already have a cardiovascular event to be the priority target for these therapies, because the benefit would be so much higher compared to others. And same thing if you have multiple comorbidities, MASLD patient with obesity and type 2 diabetes, then the choice becomes obvious, because you will have a multiple benefit of some drugs, such as the GLP-1 receptor agonist, triple, double agonist, that will also improve diabetes at the same time. So I think this is really something that we need to embrace, and the field of hepatology need to embrace, and don't be afraid to look at the other comorbidities and how you could classify your patients in terms of future therapies as well.
And this also because there was another question from Sven about who needs to be treating these patients, but this is already a little bit of the answer, I think, because it's just a multidisciplinary approach in this sense. I think that's my opinion, but I'm not sure how.
Yeah, absolutely. And I think also that from a liver perspective, because that's obvious, the bias I have, that we should not always regard it as a liver indication. I mean, if there is just fat in the liver, it's probably not an indication to treat the liver, but it's a sign that there is something metabolically unhealthy, and that globally the patient is not in good shape and something needs to be done, not specifically to solve the liver, but just take the liver as a warning sign of something that is that needs to be tackled.
And it may be also an indication for further investigation of the patient for further metabolic complications. I mean, in the majority of the cases, liver probably will not be on its own having ectopic fat. It may have underlying diabetes, it may have underlying heart failure with preserved ejection fraction, it may have underlying obstructive sleep apnea. So it may be something that you need to think when you see a patient that they present with metabolic complications due to obesity. And I fully agree with everything that has been said regarding cardiovascular protection as well as multidisciplinary approach. Absolutely.
Maybe it could also drive the choice of agent later on, because with the dual agonists with glucagon, which might have like direct effects on the liver in terms of inflammation and oxidative stress, and possibly also fibrosis. If someone already has fibrosis, it might be better to have like a combination, so dual agonist or maybe triple than maybe only a single. Maybe in the future it becomes apparent and can make choices on basis on which comorbidities are present actually. So that's something I would think.
I think also that cardiovascular outcome trials, as Cyrielle says, will be very important, because this is one of the main reasons why you choose medication, especially people with established cardiovascular disease. You want to give them something that will make them live longer and prevent cardiovascular events. So it is a more complex picture to take into account when you need to make these decisions. It becomes more and more complex. Medicine and metabolic medicine, cardiometabolic medicine, definitely. But this is good problems that we have to solve and see the evidence.
I think so, yeah. We have been splitting up everything in different organs, but in the end, everything is linked to it. So.
Everything belongs to the same patients, so.
Absolutely. What also brings me to my next question, because we're talking about weight loss and adipose tissue mass, fat mass, but what about the muscle? Because if you induce weight loss, there's some concern you might also lose muscle mass, and which is important in every patient, but the more advanced liver disease patient, and especially the cirrhotic patient, it's even more of a concern. Something that with those agents or with bariatric surgery we should be worried about?
Yes, I think that there is evidence for semaglutide that approximately 35 to 40% of the weight that you will achieve will be due to lean mass, but the majority of the weight that you will lose is due to fat mass. So the body composition, it improves, but especially for the populations that you are saying, it is important to maintain as much lean mass as you can. With tirzepatide, it appears that it is a little better. They lose a little more fat mass compared to lean mass. But what is important is we're not just giving medication. As we're saying, we need the MTT approach. So this patient needs to ensure that he's having some consultation regarding protein intake, also support for increasing physical activity. So he is trying to maintain as much muscle mass as possible. With the glucagon agonists, they create hypoaminocytemia, which has been shown in vivo models that may reduce further muscle mass. So we need to see, it is very interesting to see what will be the body composition changes with the dual and triple agonists, and whether things are getting, in comparison with GLP-1s, better or worse, or in comparison with tirzepatide. That would be really interesting.
Yeah, and this would be one parameter as well that we may be taken into account, you know, I mean, assessing muscle mass and function prior to therapy in order to make sure that the patient also have the proper management regarding any risk of sarcopenia, for example. So we will never get away from lifestyle and, you know, physical activity counseling and nutritional advice, even if we have just the drugs to take. And this is also really important to tell to the patient and educate them in order to have a very optimal management of the disease.
Yeah, it's a real teamwork, the management of those patients. It's not just us physicians, it's also a lot of other healthcare providers that we need to have with us. A final thing perhaps, and then we go really to the end of the spectrum, and again the patient with cirrhosis and portal hypertension. Do you think we still can start those drugs in those patients? Willem, Pieter, what do you think?
I would be quite reluctant, actually. I do. So the previous SEMA trial with in compensated cirrhosis patients was safe and effective. Well, safe actually. Sorry, but well, we didn't see any fibrosis regression, and I don't think we are really treating the portal hypertension with this. And I think that a lot of patients with portal hypertension also have this sarcopenic or quite sarcopenic. So I would be quite reluctant. I'm not sure if I do think that we with these patients they probably passed the point of no return for this type of medication, probably. But yeah.
There is a small study from Annalisa Berzigotti's group from a few years ago, not specifically in MASLD. It was a mixed etiology of portal hypertension patients, but that were put on a weight loss program, and there was some improvement in HVPG. But that's so far the only data I know in terms of specifically looking into portal hypertension. And I agree that specifically the issue of sarcopenia is something in those patients that needs particular attention, even if we have the safety data from the semaglutide trial. Cyrielle and Dimitris, any?
Yeah, I agree. I think there is not enough data of safety in this population. I mean, randomized trial, try to make sure that it actually have a positive risk balance, benefit risk balance. So I would be very cautious, and I think I agree. Maybe it's unfortunately probably too late to hope for an improvement just by improving metabolic disorder in this patient, and this advocates for early screening, detection, and early treatment.
Yeah, you may very well shift more towards antifibrotic therapies, maybe. Like
if one day we have
yeah. So that would possibly be a good option, but still we don't have the data, so it's just speculation.
Yeah.
However, we did not, it's maybe a little bit off subject, but there's a lot of also question when this patient reached the point of liver transplantation, where we have endless discussion whether we should, make them lose weight prior to the transplantation or after. And I totally think that once the patient is engaged in a liver transplantation, don't miss the point where he will regain weight and need, probably a therapy, additional therapy to prevent a relapse of liver disease as well. This is also something that we need to think about.
Yeah, that's a topic for our next studio.
Yeah.
Because we are now coming at the end of this studio, so I would really like to thank my three co-people, I would say, for this very lively discussion. I hope you enjoyed it. Before we leave, I would just like to invite you to next edition, next Wednesday, which will be on functional HBV cure, whether that is something we need to strive for or not, and it will be hosted by Ahmed El-Karshawi. So many thanks for joining us, and enjoy the rest of the day. Bye-bye.
Bye.
Thank you, everyone.